Okay. Hello, guys. Good evening. So there's only five of you right now. So it's a shame. However, we waited long enough. So let's get started. Uh, Yesterday we didn't really finish what I thought we were going to. So let's do it today. I think we're going to talk about a little bit about gynecology, if you're okay with it. And right after that, I think we're going to talk about some topics. I don't think we're going to make it because today is actually a practice class, right? So let me get started with our presentation. And when we are done, when I finish this topic, we will start with our practice class the way we already did. Okay. So let me know if you can see my screen. Okay. Hey, Danitza, how are you doing? Okay, so do you see my screen, right?
Yes.
Yes.
Okay. So we're going to talk about birth control, okay, and gynecology. So this is my table of contents. Today we're going to talk a little bit about the Pearl Index, which I don't think if you ever heard about. The World Health Organization categories related to, sorry, someone just wrote. Okay, 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 thank you for letting me know, Danitza. She will be welcome anytime she joins our meeting. Okay, thank you. Okay, the categories are related to contraceptive methods. That is what we're going to talk about. Behavioral methods, which is actually, well, some people might think that is this behavioral methods are quite easy, but there are some things you might not know that I will explain to you. It's really interesting, okay? And the barrier methods, the IDU, the hormone-based methods and surgical methods. I think we're going to do it by tomorrow because today we have our practice class, so let's make it quick, okay? So does anybody know what the Pearl Index is? Anybody, guys? Pearl Index? Those senior students? Any of you? Does anybody know what the Pearl Index is? Okay, so actually, this is an index that tries to make categories from the contraceptive methods, okay, based on how effective they are. So, how is the Pearl Index made? How is it made? First of all, some researchers had 100 people, okay, and those 100 people were taught. The researchers taught them, like, you know what taught is, right? The past of teach. They taught them how to use one single method. So the researchers taught these people how to use correctly a contraceptive method. Okay, just one contraceptive method. We have a lot of contraceptive method, as you already know, right? The female condom, oral contraception, hormonal ring, um, contraceptive injection, and there's a lot, right? So these people were actually had instruction on how to use correctly the correct use of one single method. And they were asked to use this one method for a whole year. Okay, so we turn this into a percentage. So at the end of the year, we have this 100 people that used one contraceptive method. And at the end of the year, we investigate how many of these people had been pregnant. Okay, so the Pearl Index is actually the number of confirmed pregnancies in 100 people who correctly used one method, one contraceptive method in 1 year. Okay, so it is like how many failures this one specific method had, right? Because they were, well, we measure the failure of one method by the pregnancies. Easy, right? If anybody has any doubt about this, because this is actually the main point of the today's topic, today's class, okay? So the lower the Pearl Index is for one single method, the more effective it is. So if by the end of the year, for example, only 2 people got pregnant, it means that only 2%, it had a 2%, yes, a 2% of failures, right? So the lower the Pearl Index is, the more effective this method is. Easy, right? So the World Health Organization recommends methods with Pearl Index from 1 to 4 and considers a method that is actually effective with a Pearl Index lower than 1. So it means that in 100 people, less than 1 person got pregnant at the end of the year. Okay, so let's look at this from another point of view, the opposite point of view actually. The higher a Pearl Index is, the less effective this is, right? It means that at the end of the year, more people got pregnant using one single method, and it had been used correctly, right? Easy, right? So as I told you, the World Health Organization considers a method as effective with a Pearl Index lower than 1. That means at the end of 1 year, less than 1 person got pregnant. Okay. So there's also another categories considered by the World Health Organization. We have 4 main categories. Okay. Category number 1 is based on one single method that can be used under any circumstances. Number 2 means this one method is generally allowed under periodic controls on one physician, right? The third category says that one method is only allowed if there are not any other methods considered better for a determined patient. And the fourth category tells us that this one method cannot be used in this specific patient. Okay, so we have the first category here, which is are the behavioral methods. Can anybody tell me what behavior means?
Conducta.
Great, yes. So these are methods that are related to the behavior of one person or a couple actually, right? So here we have this method, the Hinonaus, right? Which is actually also known as calendar method. the Billings method, the basal body temperature, the syntothermic, and the coitus interruptus. So we're going to talk about each one of them, and well, let's do it. So the Hinunau's method, also known as calendar method, is based on identifying the fertile period of a person, of a woman, right? And before we tell our patient how to use this method, we have to know, to identify if this person is allowed or not to use this method, because not every woman can use this method. So what we have to do first is to identify if this person is able or not to use it. So how do we do that? First, we ask our patient to register the cycle duration of at least 6 months. Okay, at least 6 months. And our patient is going to do it. And she has to register the longest cycle and the shortest cycle, the longest and the shortest one in duration, in days, okay? So, okay, here we have our patient that just registered that kind of the information that we asked for. And what do we do next? Then we apply, then we can ask ourselves, can our patient use this method? Then we have to do some math, a subtraction actually. Here we have, sorry, okay. Here we have this number that she's going to register, right? The longest cycle and the shortest cycle, both are numbers because we're measuring those cycles in days, right? So here we have to subtract the longest minus the shortest days of each cycle, the longest and shortest. We subtract the longest minus the shortest, okay? And how do we, what do we have to do next? We have our result from this subtraction, okay? And if the result is lower than 10, our patient can use this method. If the result is higher than 10, our patient cannot use the method. Because if our subtractions result is higher than 10, it means that our patient has irregular cycles, right? And this method is not for that kind of cycles. It actually has to be related to regular cycles. And how do we know if a woman's cycles are regular? If we do this subtraction and the result is lower than 10. If it is lower than 10, it means that our patient has regular cycles, and therefore she can use this method, okay? So until this point, the only thing that we know is that our patient can or cannot use the method. What do we do next is, if our patient cannot use this method, well, we have to think about some other method she can use. If she is able to use this method, which means our subtractions result is lower than 10, right? Then we go to the next step. So what do we do next? We also we have to take into account the longest and the shortest cycle days, right? And then we have to subtract again the longest cycle minus 11. This both numbers are constant numbers. Okay, so the longest cycle minus 11 and the shortest cycle minus 18. So what do we get from that? Uh, we're going to do it with one example, okay? Because this is important. So here's an example. Let's say that we have our patient and she registered, let's say her last 9 months related to the duration of her cycles, okay? Because they have to be at least 6 months, right? So she registered that her longest cycle was 32 days and the shortest one was 26 days. What do we do next? As we said, we subtract the longest minus the shortest, right? Our result is 6, right? So is it lower than 10? If in this case it is, right? Lower than 10, 6 is lower than 10. If it wasn't, our patient couldn't or wouldn't be able to use this method. In this case, since the result is 6 and it is lower than 10, our patient can use the method. So in a patient who can or is able to use this method, what do we do next? We take our longest and shortest cycles again, and the longest, well, we had this mathematical procedure, the longest cycle minus 11, right? So here we have 32 minus 11 is 21, and the shortest, which is 26 minus 18 is 8, right? So it means that between the 8th that comes from here, between the 8th and the 21st days of the cycle, these days are considered fertile days. Okay, so at least in my case, some professors used to tell me that this method was much more simple than this. Um, some professor even told me that um, we had to know how to identify the ovulation day, which would be in some regular people, people who had a regular cycle, it would be the 14th day, right? In which occurs the ovulation. So this, well, the patient would have to start counting from the first date of the menstruation, right? From the first day of menstruation being the first day. And with a calendar, take into account which day would be the 14th day and consider that the ovulation day. And from that day, avoid having sexual relations 3 or 4 days before and 3 days after that ovulation day. And the patient would have to avoid having sexual relations 3 days before or 3 days before and 3 or 4 after days after the ovulation day, which would be the 14th day, right? However, if we count the days, it's, well, these days are actually would be almost 2 weeks, right? So this is a much more efficient way of knowing this method, actually. So does anybody have a question about this one? Okay, let's go on to the next one, okay? To the next one would be the basal body temperature method. As we already talked about this, remember, we have actually two phases in a woman's genital cycle, which are the follicular phase and the luteal phase, right? In the first phase, which is the follicular phase, we had our FSH very low, but this this low concentrations of FSH made some group of follicles to mm, reach a maturity state, right? And then uh, at the 14th day, we had an increase concentration of LH, right? We also talked about it, the trigger effect, right? El efecto gatillo, right? So this higher concentration of LH is the trigger effect for the ovulation. Right after the right after the increase of the LH concentration comes the ovulation, and that is why this peak is actually called the trigger effect. Okay, then the ovum is released and the corpus luteum is formed. This corpus luteum actually synthesizes a hormone, which is the progesterone, right? So this is the point after the 14th day where the luteal phase begins, right after the formation of the luteal corpus, because it produces progesterone. So the progesterone levels start to increase. So what does this have to do with this method? Okay, someone just joined in. Okay, so here we have the progesterone levels, right? Well, they start rising on the right after the ovulation, right? So this increased concentration of progesterone is actually sensed by the hypothalamus. In the, well, at this point, at the hypothalamus, we have our thermoregulator center, right? At the hypothalamus. And as a response, the hypothalamus increases the temperature between 0.3 to 0.8 Celsius degrees. So, as you can see here, the temperature increase actually begins 1 day after the ovulation day, which would be the 14th day, right? 1 day after this would be the 15th day. On this day, our patient, well, the patient who is following this method would actually register an increased temperature on day 15. Okay, so this temperature increase lasts from 11 to 16 days. Okay, and if it lasts less than 11 days, we can think of a diagnosis. As I already told you, the progesterone increased levels make the hypothalamus increase the temperature, right? And if this increased temperature lasts less than 11 days, we might have to think in this condition, which is corpus luteum insufficiency. Why insufficiency? Because this corpus luteum is not producing enough progesterone on this part of the cycle. So the levels are lower than usual and the temperature is not as high as it should be. And if it lasts longer than 16 days, we might have to think about pregnancy. Does anybody know why? Hello, are you there, guys? Where is the progesterone produced during pregnancy? Hello, guys. Anybody? Okay. So progesterone is actually produced at the corpus luteum, right? But its levels decrease by the end of this part of the cycle. If there is pregnancy, the placenta produces progesterone. Okay, so it produces, it synthesizes, releases progesterone from the first day of pregnancy for the rest of the pregnancy time. Okay, so progesterone is still high because another organ is producing it and no longer the corpus luteum. So the progesterone levels are higher and the temperature will be increased during the whole pregnancy period. Okay. But what if there is no temperature increase? I mean, there are some kinds of diseases. As you can see here, this cycle has two main phases, right? The follicular phase and the luteal phase, right? In some diseases, there is no, there are not two phases. There is only one phase. Those are the monophasic diseases. That is, well, that's where this diseases come from, based on the phases of our normal cycle. Does anybody know what kind of disease is related to a monophasic cycle? Hello, are you still there, guys? Okay, I'm gonna have to ask one by one. Brisa, are you there?
Yes, I am.
Okay, Brisa. So do you know any kind of disease that might be, well, that might have one phase at a cycle and not two, which is normal?
Maybe it could be when you can't, when you are not able to ovulate.
Great. And what kind of disease would you think of?
Mm, I'm not sure, but could it be ovario polycístico?
Awesome. Yes. Polycystic ovarium. Great, Brisa, you got it right. If there is no temperature increase, we would have to think that, okay, we would have to think that there was never ovulation and therefore the corpus luteum was never formed. So the progesterone levels are never high and there is only one phase, which corresponds to the follicular phase. And this disease that Bristol just told us, there is no an increase of temperature, which would be normal, right? Because of the levels of progesterone. In this kind of diseases, there is never ovulation, and therefore the corpus luteum is never formed, and it does not produce progesterone. So that would be an example of a disease that is actually monophasic disease, right? Okay, great. You got an extra point, Brisa. So what is this method based on? This patient might have to register her temperature daily in the morning after at least 5-hour rest and one measuring way. That means oral or axillary or I don't know, any any other method to measure temperature. Okay, but following only one method every day. Okay, and before and do it before any other activity. So here I have an example. Okay, so here we have the basal body temperature method. We consider the 14th day, right, as the day in which ovulation occurs, right? So, and our patient recognizes her ovulation day one day after, because as I told you, the increased temperature begins one day after the ovulation day. So it would be at the 15th day, right? So she recognizes an increased temperature at this day. So she might say at that point that she had the ovulation day one day before, right? And then she since this person is using this kind of method, she would have to avoid intercourse or sexual relations until the morning of the fourth day. So that would mean until day number 18 of the cycle. However, we all know, does anybody know how long could a spermatozoid live inside the genital organs of a woman? How long can a spermatozoid live? Okay. Constanza, are you here?
Yes.
Okay, Constanza, do you know how long can a spermatozoid live uh, in a genital, on a feminine genital?
No.
Okay. Anybody, guys? Okay, Marcela, you raised your hand.
I'm not pretty sure, but I think it's from about 2 or 5 days.
Okay. So our mean cipher would be 3 days. Okay, from 2 to 5 days. You're right. Our middle point would be 3 days. Okay, thank you. You get an extra point. Let me write it down. Okay, so spermatozoid is able to live 3 days inside feminine genitalia. Okay, so now that you have this information, we have to consider a possible pregnancy 3 days before the ovulation day. So this 4 days after ovulation day are considered fertile days, right? But the 3 days before the ovulation day are also considered fertile days because spermatozoids can live around 3 days inside feminine genitalia. So what about the previous day to ovulation? Those 3 days are also considered fertile days. Okay, so this is a cause of mistake for this method because our patient is only going to recognize the days after the ovulation day. So from day 15 to day 18 are considered fertile days, right? But what about these ones that are considered also fertile days? So this is a cause of mistake for this method, okay? This is why this is not quite, well, this is not the better method, actually. So we're going to the next one, the Billings method, right? So as you know, estrogens and progesterone have their own effects on the cervical mucus. So I found this image, which is kind of interesting to analyze, right? We have this dry phase in which has these characteristics. It's like dry and mostly dry and kind of sticky, right? Sticks to the patient's fingers. Then we have the sticky phase, which is considered also non-fertile from days 4 to 6. It is white or cloudy and forms sticky globs. Okay. As the cycle goes on, this one is the next phase, the creamy phase. It says semi-fertile, right? It would be from the 7th to the 9th day. It has some other characteristics, which is that the cervical mucus is creamy or cloudy and thick. And the clear phase is actually the most fertile time period of the cycle, in which the cervical mucus is actually stretchy and slippery. Okay, you also know this. This is kind of easy. And what about the syntothermic method? It combines, this syntothermic method actually combines the basal temperature method, Billings method, and the calendar method. And since all these methods are combined, it will have a different Pearl index if we consider each one of them separately. And the coitus interruptus, right? It would be, well, you know what this is about, is when have an intercourse, during intercourse, just before ejaculation, uh, the male part of the couple takes away his penis and has his ejaculation out of the vagina, right? So the best contraceptive method in the world is a good education. So here we have the Pearl Index for behavioral methods. The calendar method has a very, very high Pearl Index, which is 9. Remember, I told you that the World Health Organization considered an effective method with a Pearl Index lower than 4, right? So this calendar method is actually not good enough. It tells us that from 100 people who used this method, 9 of them got pregnant. So it is not the best method, right? The Billings method, which is the cervical mucus method, right, has a Pearl 5 of a Pearl index. The basal temperature method is actually better because it has a Pearl index of 3. As I told you, the syntothermic is a combination of all 3 previous ones. And since we combine all these methods, the Pearl index is actually lower than 1. And as I told you, the World Health Organization considered an effective method if it has a Pearl index lower than 1. So since this is the result, the syntothermic, which is the combination of the previous ones, is a good method. However, since there is no barrier, it is not the best method to prevent infections, right? And the coitus interruptus has a Pearl index of 25. I mean, those people who use this method, from 100 people, 25 of them at the end of the year get pregnant. So it is not a good method at all, right? Let's go on to the barrier methods. This is easy because there has its name itself is telling us They make barriers between direct contact between penis and vagina, right? So we have the male condom, the female condom, spermicidal foam. It's not actually just foam. It would be better to call this spermicidal um, agents, right? The diaphragm and the sponge. There are some other, however, we're going to focus on these ones. So when we're talking about condoms, we have the male and the female condom. The male condom is actually made of latex and diminishes the risk of STD, which means sexually transmitted diseases, right? Infectious diseases that are related to sexual transmission, right? The only condition that would make a person not stand for this kind of method would be latex allergy. And its Pearl index goes from 2 to 15. Okay, so it is, there's, it's a little controversial, right? The Pearl index here. The female condom, it is, well, its composition is quite different from the male condom because it is made of polyurethane and it can be inserted up to 8 hours before intercourse. It has a Pearl index from 5 to 21. So here we do not have, well, it's not that controversial. We could say that this is not better. This is not the best method because it has a Pearl index higher than the male condom. So in Pearl index conditions, we would say that the male condom is more efficient than the female condom. Spermicidal substances. Well, these are chemical substances that immobilize and destroy sperms. The effectiveness lasts up to 2 hours and it has different presentations. Would be jelly, suppository, foam, film. Does anybody know what foam is? Its translation?
Espuma.
Great. Yes. So there are different presentations of these spermicidal substances. The most used one would be an anoxanol 9, and it have, well, they have a Pearl index from 18 to 29. Their Pearl index is actually really, really high. So as they were actually created as a singular use, they were not that effective. So they were also produced with a condom or barrier method, which would be condoms, right? So there are some brands of condoms, mostly male condoms, that already have these spermicidal substances. So we combine the barrier method with a chemical method, right? Which is actually kind of controversial based on the differences between those condoms that have spermicidal substances. There is no much difference according to the Pearl index than those that do have these chemicals. The diaphragm is actually a circular device with a silicone or latex membrane. It is actually not the best method because it has some difficulties related to the appliance because it needs to be applied by a physician, a personal health carrier giver, right? And it has a Pearl index from 9 to 32. It could be applied by itself or with a spermicidal substance. Okay, so I have a lot of more slides. However, I think we are going to stop here. Okay. we'll finish tomorrow because it's almost 1 hour already, and we have to go on with our practice class. Does anybody have a question about what we talked about today? Okay, so let's go on with our practice class. And we are going to begin with Brisa. And as you already know, I'm going to call you each one. I'm going to call each one of you so we can finish, okay? Sorry. Okay. So, give me 1 second, guys. Okay, guys, so let's get started with our practice class. We're going to start with Brisa, and I'm going to call each one of you. After we finish with Brisa, will come Constanza, right after Danitza Burgoa. After her, we have Danitza Zambrana, Marcela Guzman, Mariana Sagines, and Paola, okay? So I'm going to start with this. Okay, so I'm calling you, each one of you, to join us. Brisa, are you here?
Yes, good night.
Hey, how are you doing, Brisa? So give me 1 second, please, for me to start measuring. Okay, from now we have our 15 minutes. Okay, so do you have any kind of doubts until this point from the class yesterday and today's class?
You said this word, I can't remember. Last, I think. I don't know what does it mean.
Okay, LAST, right?
Yeah,
Is that the word?
yes, it is.
Okay, last in Spanish would be durar.
Oh, okay. I thought
okay.
it was like the last one.
Okay, it actually has different meanings, right? So when we say something lasts, there's actually an expression that says this is lasting forever, right? Esto dura demasiado, right? This is lasting forever. This lasts too much. For example, when we have very long classes, you might think, oh, this lasts forever. Okay.
Okay, I get it.
Okay. So do you have any other doubt? What could you tell me about what we talked about yesterday about achalasia?
Like what achalasia is?
Yeah.
Oh, well, it's a disease that is not too much frequent, and it difficulties like the when you eat something or any kind of liquid, and the esophagus is doesn't working is not working well, so you cannot eat, and it doesn't go through the stomach, and it I think it is produced by a nerves damage.
Yes. What kind of nervous cell damage could you find in, for example, pathology? You know, pathology, they see structures under the microscope, right? So in achalasia, what would you find talking about pathology?
Oh, I don't remember right now.
Okay, yesterday we said that, do you remember the myenteric plexus, which I don't remember the name, Auerbach's plexus, right? Uh, you remember Auerbach's plexus is actually a motor one, right? It gives our circular and longitudinal layers, muscular layers, to contract and relax, right? So there are some, you might have read about the interneurons.
I thought that the damage were on the muscles.
Okay, it is actually, there is actually damage on the neurons, on these ones, the interneurons. This produce two kind of molecules related to nitrogen and uh, VIP, which in Spanish is peptide inhibidor vasoactivo, right? So this both molecules make the lower sphincter of the esophagus to relax. So the food can go through the lower sphincter into the stomach, right? So in pathology, we would find destruction of interneurons on the Auerbach's plexus. Okay.
Okay, what does intraneurons mean?
In Spanish would be interneuronas, right? And
Ah, okay.
they are inhibitory neurons, right? They inhibit some functions. In this case, they make some muscles relax. In this case, the lower esophageal sphincter. These cells make the lower esophageal sphincter relax, so the food can go through this sphincter into the stomach. So in this disease, these neurons are destroyed and they never get to produce these both molecules, and the lower sphincter never relaxes, so the food is stuck in the esophagus, inside the esophagus, right? So what else would we find talking about clinical features?
People that have this disease can feel bitter flavor, and they can cough at night. I remember.
Yeah, yeah, that one also, yeah. What would be the first and main manifestation or feature uh, talking about achalasia?
Dysphagia.
Awesome. What kind of dysphagia?
Uh, mm, I don't remember.
Okay, so when we could you tell me the definition or anything you know about dysphagia? What this is?
You can feel like the food and the liquids are attached in your esophagus.
Okay, so actually, yes, you're right. This is, there are some kinds of dysphagia. There are two types actually, based on the physiological concepts. Uh, when we're talking about physiology, we have two main phase, well, actually three main phases on deglutition, right? The first one is a cerebral phase. The second one is a transition in which you start swallowing your food and goes from your mouth into your esophagus, right? And the other part is the conduction phase, which is related to the esophagus. So we have two kinds of dysphagia. based on the part of the deglutition system that is affected. For example, when you have an inflamed tonsil, you know what tonsil is, right?
Yes, yes, I know.
Okay, so when you have an inflamed tonsil, it's difficult for you to swallow, right? So it is actually, you also have dysphagia, but this dysphagia is called transition dysphagia because of the transition phase of deglutition. When we're talking about achalasia, we also have dysphagia, but this one is related to the um, conduction through the esophagus. So we have this symptom is actually called conduction dysphagia. Okay, so dysphagia, cough at nights, and what else would we find?
Yesterday you say that pneumonia too, I think.
Yes, in the long term, yes, the food would go into the airways and it could get infected, right? Yes. And the third one would be weight loss, right? In the long term, what would you think if a patient has also conduction dysphagia and also has weight loss, but it is, well, loses weight very rapidly. This is, let's say, 10 kilograms in 1 month. That would be very fast, right? What would you think about if you had this kind of patient? Would you think of achalasia?
Maybe it could be reflux.
No, because in reflux, patients do not lose weight that fast. You would actually have to think about cancer, and let's say about some esophageal cancer, okay? Because you also have like a blockage in in this patient's esophagus, and the increased number of cells would make a patient lose weight very rapidly. So when we're talking about achalasia, our patient would have conduction dysphagia and weight loss, but in a long term. Okay. So what else? Let's see. Okay. If you ask for an X-ray, chest X-ray, what would you expect to find in a patient with achalasia?
Some air, I think,
Here? Where?
on the esophagus, on the first part of the esophagus.
Okay, great. It would be like a dilated esophagus, right? Okay, what else?
Maybe some food attached to.
Yes. In some cases, well, there's actually a classification that I didn't include in my slides. It's Resendes classification that is actually related more to Chagas disease. You know that in Chagas disease, well, you know Chagas is a Brazilian doctor, right? So this guy actually had a mega. There's another diagnosis related to Chagas disease, which is megaesophagus, right? In which it gets really dilated, and the food gets attached and gets stuck in this patient's esophagus. So it would be a dilated esophagus. Yes. What else?
I think that's it.
Okay, what about you do know that when we eat, there is yes, we swallow our food, our some kind of drinks, right? But we also swallow air, right? And it is normal. It is called aerophagia, right? You swallow air, and it is normal. It's physiological. And in an X-ray, in a chest X-ray, how would you define when we swallow air? Anything about the stomach, maybe?
You can what you can see on the X-ray is the black. I
Yes.
mean, air appears like a black color.
Yes, that is the gastric bubble, right? In Spanish, la burbuja gástrica, right? So there's air inside the stomach and it is considered normal, right? So when a patient has achalasia, this person does not swallow his or her food, liquids, or air. So there is no gastric bubble inside the stomach in an X-ray. Okay. What about barium contrast study?
Is that when the person has to drink this liquid, and so the doctor can diagnosticate better? I don't know if it's that.
Yes, you are right. Yes, we ask our patient to swallow this barium contrast, and then we take an X-ray. Okay, and there is a sign actually. Do you know what sign this is?
Oh no, now I can't remember.
Okay, let me share my screen so you can. Sorry. Okay, you see my screen, right?
Yes.
Okay, so here we have the bird peak appearance. It's like a bird peak, right? El pico de un ave. Right here. You see it, right? This is a
Yes,
sign.
yes.
This is a sign, okay? And this is actually related to achalasia in a barium study, barium contrast X-ray, okay? So, Brisa, we are done for now with your 15 minutes, and don't forget to join at the end of the class so you can have the poll, the daily poll, okay? Survey.
Okay.
Okay,
Thank you.
thank you. Bye.
Bye.
Hey, Danitza, how are you doing?
Hi.
So, Danitza, do you have any doubts about what we saw this, yesterday and today?
No.
Okay, so let's talk about achalasia. Could you tell me what this is about?
Um, Appalachia. Well, it's a um when it happens when there's a disorder at the muscle of the esophageal
Anissa, are you still there?
Sorry. Sorry.
Don't worry.
Well, as I was saying, achalasia is a disorder at the esophagus, a
Okay.
muscle that affects the muscle and the motility.
Okay.
And there's a in the lower esophageal sphincter.
Great. Yes, you're right. So the lower esophageal sphincter never relaxes, right? So the food gets stuck inside the esophagus, right? So,
Okay.
what kind of medical, well, let's say, what kind of clinical features would a patient have?
This patient will have dysphagia.
What kind of
Um,
dysphagia?
mm, I forgot.
Okay, it would
Sorry.
be conduction dysphagia, okay? Conduction dysphagia is actually when this patient tells you that feels that his or her food gets stuck in his or her chest. Because there's another kind of dysphagia in which uh, a person cannot or is difficult for this person to start swallowing. So it is related to higher to upper structures. Okay, so in this case would be conduction dysphagia. Okay, what else?
Mm, um, this patient also presents coughing at night, weight
Okay,
loss.
okay, great. What else?
This cough um, can come uh, can maybe a pneumonia.
A pneumonia, yeah. In a long term,
Mm,
yes, it would be. Um, yes, it could be present. Okay. Um, what would happen if a person has his or her food stuck in her or his esophagus? I mean, it would smell really bad, right?
but halitosis.
Halitosis, yes. Okay, great. Awesome. Okay, so what would be the treatment for this?
The treatment it can be treated. mm, um, there's two types of treatment: the non-invasive and the invasive.
Awesome. Yeah.
Mm, the non-invasive invasive includes medication. Can how we talked about yesterday about the nifedipine. I don't know how to say it,
Yeah, it's
how to
great.
pronounce.
Yes, you're right. You are
Um,
saying it right. And what kind of medication is this more related to? I mean, this is actually medication that is given to a certain kind of patients with a different diagnosis, right? What kind of
yes.
disease would it be?
And this medication is for patients with hypertension.
Right.
Um, And yeah, it as I see in my practices, this medication was indicated to pregnant women with
Yeah.
I don't know how to say it.
Hi.
Preeclampsia.
Yes, it is actually, it would be called pregnancy-induced hypertension. Okay, hipertensión inducida por el embarazo, right? Yes, you're right, because they cannot use all types of medications related to hypertension, right? So they would have to, we would have to think of this kind of medications related to the calcium canals, right? Okay, so what else were we
Yes,
talking about yesterday?
About this
Thyroid.
disorder or this disease.
Okay, let's talk about today's class. What kind of methods do you know? Contraceptive methods, do you know?
As we talked today, the behavioral methods,
Great, awesome.
ID, barrier method.
Barrier, yeah, barrier methods. Okay. Okay, what about the behavioral methods? Did you know how to apply this calendar method?
The first one
Yeah,
was the first one.
the calendar method.
Oh yes. What was the name? Because it has a specific name.
You know, right?
Yes.
Okay, so did you know that there was some math involved? Because some professor just told me that we had to take into account the 14th day and avoid having sexual relations 3 days after, 3 or 4 days before, and that was it. How did your professor teach you that kind of method?
I don't remember. Like you were talking about calculating this method. I a subtraction. I don't know how to say restart.
Okay,
Or,
okay, subtraction, right?
yes.
Did your professors of well, this subject gynecology teach you that way, or did they just tell you to consider the 14th day and avoid having sexual relations 3 days after and 3 days before?
Actually, no.
Okay, how did they teach you this kind of method?
Well, I actually didn't read about it, and I just
Okay,
heard about it today
really?
in class. Or I don't remember.
Okay. Okay, great. So,
Not really.
because actually some professors just teach you what is easier for them to explain, right? And there, when you get to this part at the university, you're going to realize that some professors, I don't know if they don't want to, but it's like they're get kind of lazy, and they say like, okay, you read it, and that would be it. At least here in La Paz, it's that way. Some professors are not, well, do not want to teach the students in a better way. So you already know, I'm going to upload our presentation to the WhatsApp group, okay? So any other method you might want to talk about or explain me a little bit? Any kind of method you might not, you might know about.
The maybe the IDU.
Okay, great. So what could you tell me about the IDU?
Um, it's
I-
one.
I-
It, it's a device um device has a shape like a T, and and it it had it has to fit inside the uterus. It prevents pregnancy. Uh, this device stop the sperm from reaching and fertilizing
Okay, okay, great. So
birds.
what kind of devices do you know? What kind of IUD? There are, I think, actually two main kinds of this device.
Types of this device.
Yes, there are two types.
It's the long acting.
Okay, one is actually what kind? Well, how does this IUD act? What is how it is? Let's. How can I say this? How this does this device work?
Mm, like I was saying that he stopped the sperm
And how
and
does it do it?
um, with how I say it? I don't know how.
Okay, it is
You,
actually related to, well, this IUD causes inflammation. Okay, so there is, well, it causes a non-septic inflammation. So it means that there is no infection, right? But there is inflammation. Okay, so there are the inflammation pathways get activated, and they stop the spermatocytes to go through the fallopian tubes, right? And this is the main action of the copper one, right? This in Spanish is te de cobre, right? So this is the main function of that one. Okay, there's another type, as I was asking you, there's another type of IUD which has some sort of medication inside of this IUD. It actually has progesterone derivated molecules. Okay, so you're going to read it by tomorrow and tell me how that medicated IUD works. Okay. Okay, Danitza, so we're done with our 15 minutes. I'll see you at the end of the class for the survey.
Okay. Thank
Okay, see you later.
you later.
Danitza Zambrana, are you here?
Luego estaba ese índice.
Hey, Mariana, how are you
Hello.
doing? Hey, how are you doing?
Fine, thank you.
Okay, so Mariana, yesterday we were talking about two main diseases, right? One of them was achalasia. Could you tell me a little bit about this disease?
Yes.
Okay, go on.
Well, it's a disease that uh, gives in the esophagus,
Okay,
and because there isn't a relaxation of the lowest part of it.
the lower
So,
esophageal sphincter, right?
yeah,
Okay,
so food can't go into the stomach
okay, and why does that happen?
because the muscles of the esophagus can't relax. There is a problem in, if I am not wrong, in the interneuron, you call it that.
Yes, the interneurons of which plexum? I mean, in our digestive system, we have two main plexus, right? Meissner's plexus, I think it's the submucosal plexus, and the other one is the myenteric or Auerbach's plexus, right? Which one is more related to this kind of disease?
Mm, I really don't know about that. I just know that it's in the lowest part of the esophagus.
Yes, you're right. I mean, you paid attention to what I said yesterday, because some people didn't remember what cells were involved, and you told me are the interneurons, right? And you are right. The interneurons are actually inside the Auerbach's plexus, which is related to motor activity. And these cells produce two main molecules, which are in Spanish would be óxido nítrico y péptido intestinal vasoactivo, uh, which actually make the lower esophageal sphincter to relax. So in pathology, we would find the interneurons destroyed. They get destroyed, and well, therefore they do not produce these molecules, and the lower esophageal sphincter never relaxes, right? And that is the base of the disease. Okay, so what clinical features would a patient have?
Well, it would have um, long-term weight loss, uh,
Yeah,
cough,
great.
right? And conduction dysphagia.
Awesome. And what else? I mean, those are the three main clinical features. However, we have some other clinical features. Do you remember any of them?
Well, yes, I remember. But one of them I don't remember how to pronounce it.
Okay.
Uh, Halitosis.
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 Okay. Yes, you're right. Awesome. So, what kind of treatment? I mean, when let's say that you're a doctor and you have a patient with this condition. What kind of treatment would you um, give to your patient?
Well, our treatment has to be to relax the muscle that can't be relaxed. So we could uh, give him or her medication that could relieve that contraction in the muscle. That could be, mm, I don't know how to say it in English, but I remember that it was in the slide, toxina botulic.
Toxina botulínica, right? Creo que, bueno, I think you might have read about this, because yes, I did not really talk that much about it. Do you remember what kind? I mean, there are some types of botulinic toxin. Do you remember what type is related to the treatment?
If I'm not wrong, type A.
Yes, you're right. Awesome. Type A botulinic toxin. Okay. What kind of, besides that botulinic toxin, would you consider any other medication?
Nitrate.
Sorry?
Uh, I don't know how to pronounce it. Nitrate.
Nitrates.
Nitrate.
Yes. This is actually more known for treatment in heart disease, right?
In
Mm,
a,
yes. For example, Well, when we're talking about achalasia, you could prescribe this kind of medication, nitrates, right? But in what other disease would you prescribe this for? Nitrates, especially in one kind of cardiological condition.
You mentioned it, but I really don't remember.
Okay, it causes relaxation of the muscles, right? So, for example, when you have a coronary artery disease, that is its name, CAD, coronary artery disease, right? The blood flow is blocked, right? Because it has some greasy tissue inside of it that let's say like diminishes the lumen of the vessel, which in this case would be the coronary artery, right? So we would give our patient this kind of medication for these arteries to relax and reestablish the blood flow. For example, I think you might have heard or read about Prince Metal disease.
Not really.
Okay, it is actually the contraction of the muscle cells which are part of the coronary arteries, and they could cause an infarto agudo de miocardio, because of the contraction of the cells which are in the wall of the arteries. So you could also give nitrates to relax the cell muscles, the muscle cells inside the arteries. Okay, you're right. Could you tell me anything about the other disease that we were talking about, which was hypothyroidism?
Well, yeah. Um, well, first of all, the thyroid is the biggest gland in our body, and that hypothyroid can is called, I don't know how to explain myself. Sorry, I'm trying to further my idea.
Okay, don't worry. I mean, this is what this practice class is for, right? For you to get fluent in English. Okay, you can go ahead.
Well, yeah, the main feature of this condition is that our patient is going to be really tired, or has I don't know, se me fue la palabra, debilidad,
Weakness, okay.
and that that is because there is lowest amount of a protein, if I'm not wrong, T3.
Yes, because the T3 is actually the active form of the hormones, the thyroid hormones, right? Yes.
Yeah.
So there's a lower concentration of thyroid hormones, right? Okay.
Yeah.
Do you remember? Yeah. Okay. Go on.
There are three. I don't know how to say it, but three types of hypothyroidism. That it could be primary, secondary, and tertiary.
Okay. Yes, you're right. What are
That's
those?
all
Okay. What do you remember? What is the difference between those three that you mentioned?
Well, it's about where they begin. I don't know. Like one of them is in the third class,
Okay, that is
and
the
the other,
primary. Okay.
yes, the primary, and the other two are in the pituitary gland, and the other one in the hypothalamus.
Okay, it's hypothalamus. Okay.
Hypothalamus.
Yes. Okay, you're right. So when the affected part is the thyroid gland, we have primary hypothyroidism, right? When the affected part is the pituitary gland, as you said, is secondary hypothyroidism, and when the defect is in the hypothalamus, we have a tertiary hypothyroidism, right? And do you remember what, I mean, we have primary, secondary, and tertiary, right? When the secondary and tertiary hypothyroidisms are also known by some other term together, secondary and tertiary. Do you remember the term?
Don't really remember.
Okay, it is actually central hypothyroidism. Okay,
Central?
yes, both secondary and tertiary are considered central hypothyroidism. Okay, so what about today's class? Do you have any doubt, or would you like to tell me a little bit about any contraceptive method?
Well, I can do it. I can explain.
Okay,
Well, today we learned about Pearl Index.
okay,
That is the number of people in a group of 100 people that got pregnant in a year using a contraceptive method. Um, the well, I can explain one of them if you ask me to.
okay, you can choose. I mean, the one you feel most comfortable with.
Okay. Um, well, the calendar method.
Okay,
That and the special part of this one is if we can ask, well, it's when we have a patient, we have to ask if we can, if we can use it, um, if it's going to work on her.
exactly.
And
Yes, go
in
on.
that way, we have to do, well, and if you want to call it that way, an exercise between the longest and the shortest cycle that she has in at least 6 months.
Great. Yeah.
When we are going to, se me fue la palabra, restar.
Okay, subtraction. Okay, subtraction is the operation, right? And we were talking about the sign. It would be like something minus some other thing, right? Like it's subtraction and minus, right? Okay, go on.
Okay. We are going to have the amount of days in the longest cycle, and that number we are going to put it minus the shortest cycle, also in days. And if is less, if the result, the final result is less than 10, the patient could use this method. But if it's more than 10, it means that she might have irregular cycles, and it is not as good that she tries this kind of method.
Okay, great. You paid a lot of attention to what I was saying. Yes, and what would go next after determining if this patient can or cannot use? Let's say that your patient has this subtraction result, for example, 7. Could this patient um, use this kind of method?
Well, yes, because it is not more than 10.
Okay, and what would you do next?
Well, there are the next step to this method is that well, we have two numbers that goes along with the longest. Longest is it's 11 and the shortest is 18, with the result of I don't know how to explain it. Just give me a second.
Okay, you're doing great.
Well, with the total result of the longest cycle, we do another subtraction that is going to be the days of the longest cycle minus 11. That is the number that they give us to do this exercise.
Yes.
And we have a result of it. And then we do the same, but with the shortest cycle days. Their total days minus 18, and we are going to have another result. And those are going to be dates that inside of the month are going to be considered the days that the woman can get pregnant.
Let me tell you, you did it great and you understood the whole thing. Okay, you did great. And if you have any kind of doubts, you can tell me now.
No, it's okay.
Okay.
Just one thing. It's more like a favor. In I don't know if I could.
Yeah, sure. Go on.
In the next practice class, I don't know if you could do in a reverse way. I know that we start with the first ones in the list, but I live here in La Paz, and for me it's like 10:40 right now.
Yeah.
So
So,
it's
okay, we're going to do it backwards the next practice class, okay? So, yes, it's fair, right? It's okay, let's do it that way in the next
thank
class.
you very
O-
much.
Okay, don't worry about it. And I'll see you at the end of the class, please, for the survey, okay?
Okay,
Okay, I'll see you
thank you
later.
very much.
You're welcome. Hey, Paul, how are you doing?
Hi.
Okay, from now on, you have 15 minutes for the practice class, okay? So yesterday we were talking about two main diseases. One of them was about achalasia. Could you tell me a little bit about this disease?
Um, I don't remember the achalasia. I remember the hypothyroidism.
Okay, hypothyroidism. Okay, go on.
Okay. I remember that the thyroid is a gland, right?
Okay.
I grow the thyroid. Have two lobes, right and left. I smooth. I must. I don't know what to say. I smooth. Pyramidal lobe. 10 to 20. No, 4 centimeters. 4 centimeters. Uh, what do you say four in English?
How do you say what?
Four.
Oh, you mean like the measures, right?
De multiplicar, yes.
Yes, okay. It's like when you say, when we're talking about the thyroid, right? It's like 4 centimeters, okay, centimeters by would be the word
Okay.
by
The
two,
centimeter.
yeah, by two and by 1.5 to 2, right?
Yeah, I remember that. And I would like to explain the thyroid physiology, but because I love physiology and I would like learn more about this. This is the physiology in
Awesome. Yeah, I also like a lot of physiology because it's the basic topic in which you can relate
yeah
to diseases, right? That
yeah.
is how you start learning actually. Yes, yeah, go on. I mean, I would like to hear about physiology.
Um, I remember I read the T4 and T3 in my book of physiology, and I don't know about this disease, hypothyroidism. But remember the T4 is fast than the T3. I don't know. I'm the good position. I don't know. Um, I know the T4 is reserve form and the T3 is the active form.
Okay, yes, the active form is actually T3, right? And 80% of the T3 comes from T4 actually, not directly from the gland.
The T4 comes the T4 comes or I don't know, se vuelve or
Yes.
T3, right?
Yes, it turns into T3, right? T4 turns into T3.
Turns.
Yes, and how does that happen?
Um, I remember that the thyroid gland, the T3, the percent is 10 to 15%. In T4, 85, 90%. And I think that T3 is very fast than T4.
Okay, and how does T4 turn into T3? Do you remember?
Um, it's like is for a hormone, TSH. TSH, sorry, TSH. I don't remember that the turns. How turns T4 and to T3. Can you explain this, please? I write. I would like to write the some concepts about these turns.
Okay, great. Let me open my presentation so I can show you, okay?
Okay, thank you.
Um, by any chance, do you understand a little bit of Portuguese?
Uh, no, really.
It's a shame because I have these awesome books in
Oh, okay.
And
That's
in
awesome.
Portuguese, that they're just what you like reading.
Yeah, I would
And
like.
anyway, I'm going to upload it to the WhatsApp group, okay?
Okay, thank you very much. I would like to read this book.
Okay, I'm going to, um, where is it? Okay, you can see my screen, right?
Yeah, yeah.
Okay, so here we have the T3 and T4. As you said,
Yeah.
the active form of the hormone is actually the T3, right?
T3 is the fast than 3-4.
Yes, you're right.
Okay. Okay.
Okay, so I mean, there is much more T4 than T3. You read that, right? In your book, you might have read that.
Yes.
So in our blood, we have more T4 than T3. So in a peripheral organ, it has to turn, T4 has to turn into T3. For that, we have this enzyme, deiodinase. In Spanish, for you to look for it,
Okay.
this is desiodasa. Desiodasa, okay? So this enzyme, deiodinase, in Spanish would be much easier for you to understand. So esta enzima es la desiodasa, ¿ok? Entonces la desiodasa lo que hace en su nombre, incluso está diciéndonos que hace, desiodasa, esta enzima le quita un yodo. Entonces, como T4, o sea, la tiroxina tiene 4 yodos, por eso es T4, ¿no es cierto? Y T3 tiene 3 yodos, entonces la desiodasa quita exacto, le quita un yodo a la T4 y se vuelve T3. We have 3 main types of deiodinase. Type 1, type 2, and type 3 deiodinase, okay? Type 1 is actually located inside the liver and the kidney. Type 2 is in the central nervous system and greasy tissue. This type 1 and type 2, I'm going to say it in Spanish for you to understand it better. Desiodasa tipo 1 y desiodasa tipo 2 le quita, como te dije, un yodo a la T4, ¿no es cierto? Pero le quita un yodo en específico, que es el yodo que está en la posición 5'. Entonces le quita el yodo de la posición 5' y se vuelve T3. So, type 1 and type 2 deiodinase have one main result, which is T3, right? Yeah. This T3 is actually the active form of the hormone. We also have a different type of deiodinase, which is type 3. What does this do? This one also takes away one iodine, but a different position iodine. So this type 3 deiodinase is located in this organ, which is the placenta, right? So when a mother's hormones are going through her vessels and reach the placenta, if this organ didn't have this type 3 iodinase, these hormones, which actually are produced by the mother, would go into the child and would cause hyperthyroidism because of the larger amounts of hormones, right? For that not to happen, this tissue has this type 3 deiodinase, which takes away also an iodine, but takes a different iodine rather than this type 1 and type 2. So we have as a result the RT3, which is reverse T3. This reverse T3, RT3, is a non-active form of T3. It does not have any action, so it protects the baby from the hormones that actually are produced by the mother. So that is how T4 is transformed in or turns into T3 by this enzyme. In Spanish, desiodasa. Okay, deiodinase in English.
Yeah, yeah, the nice.
Okay. And there's actually another deiodinase. Type 2 and type 3.
Is it so complicated?
Yeah, it looks complicated because of the composers, right? Yeah, it's not. I mean, we do not have to learn everything. This is more for like I don't know.
I think I will see this thyroid physiology and the next year.
Really?
Yeah, because I'm not this year I not carry the pathology. I'm second year of medicine. The next year I will go to the third year.
Okay, so the next year you will be seeing pathology, right?
Yeah.
Like pathophysiology, and you're going to
Yes.
see this kind of stuff. Okay,
But
great.
this course is very. I learned so much in this course.
Oh, that's great.
Yeah.
If you want me to, I like teaching, and in Spanish would be much easier for me. And if you and some of your classmates want me to explain something, you can write it in the WhatsApp group. So
Thank you.
we can do it better, because in English it's kind of difficult, right?
Yeah.
To understand each other, it's kind of difficult. So I think we are almost done with our 15 minutes.
Oh, thank you.
Okay, so I'll see you at the end of the class for the survey, okay?
Thank you very much.
Okay, you're welcome. Okay, see you later. Okay. Hey, Valeria, how are you doing?
Hi, fine. And you?
Thank you, I'm fine. I was talking to one of your classmates and asked me if for the next practice class we could start with, well, backwards with the people that we actually finish with our practice class. That would make you the first one. Are you okay with it?
Yes.
You're happy, right? Yeah, okay. So
Yes.
our next practice class, you're going to be the first one, okay? So we make it like more fair for everybody. Okay, so Valeria, from now on we have 15 minutes. Yesterday we were talking about two main diseases, right? Achalasia and hypothyroidism. Which one would you like to talk about?
Hypothyroidism.
Okay, great. What could you tell me about this disease?
Hypothyroidism is a condition in which the thyroid gland doesn't produce enough hormones,
Okay, great. And what else? What else could you tell me about this disease? Any clinical
The
features
most,
or okay?
the most common symptoms in adults are weight increase, uh, change in voice, dry skin, fatigue,
Okay, awesome. Okay, well, you were talking about the voice, right? How could you use a term related to this kind of voice that this patient might have? We talked about it.
Yes, we talked about yesterday. I don't quite remember then. What was the word to describe it? No me acuerdo.
Okay, do you remember? It sounds like an animal.
Ajá, ajá, pero, wait. The- mm, no, no, I don't remember.
Okay, it's horse voice, right?
Horse
Eh,
voice.
yes, it sounds like the animal, right? Okay, horse
Uh-huh.
voice. Okay, what else would this patient have?
What else? What else? Is a disease that cannot be cured?
Okay, yes, it cannot be cured. It just
Mm-hmm.
could be controlled, right?
Control, uh-huh. Mm-hmm. And I don't know what else can I tell you.
Okay,
Is diagnosed by the blood test called TSH?
okay, TSH. And what kind of, well, there's a main classification for this hypothyroidism, right? Which is the primary, secondary, and tertiary hypothyroidism. Do you remember?
Isn't it just hyper and hypo? No.
When we're actually talking just about hypothyroidism, right? And there's a classification: the primary hypothyroidism, secondary hypothyroidism, and tertiary hypothyroidism, right? Do you remember?
Yes. I think, yeah. You want me to explain the classification?
Yes. What is the main difference between those three types?
That in the primary, the thyroid is beginning to stimulate. No, I don't know how to explain it.
Okay. So in the
Then I
primary,
do. Uh-huh.
in the primary.
Something about 90.
Okay, go on. I'm listening.
I think that the primary, it was categorized by the high TSH. I remember the percentage, 90, I think. Oh, I don't quite remember.
Okay, the primary hypothyroidism is related to the dysfunction, the lack of function of the thyroid gland. Okay, the secondary is related to the dysfunction in the pituitary gland, and the tertiary is related to a dysfunction in the hypothalamus.
Okay.
Because remember, we have an axis, right? As
Mm-hmm.
all of the endocrine system, we have axis, a lot of axes actually, right? In this case, what would be the axis formed by?
The axis?
Yes.
What I didn't understand.
Okay. In when we're talking about the endocrine system, we have axis, right? Like in when we're talking about, for example, another axis, which is in Spanish, eje hipotálamo hipófiso gonadal, por ejemplo, right? In this case, what kind of axis would be?
Hypothalamic pituitary thyroid.
Awesome. Yes, that is the axis. Okay. What would be the treatment for this disease?
I don't know what is the name in English. Well, I don't with The component, bueno, I have a hypothyroidism. I take Eutirox, pero I don't know what's the composition, the
Okay,
components.
okay. Okay, it is levothyroxine, right? It is
Levothyroxine, levothyroxine,
actually T4 is thyroxine, right?
Mm-hmm.
So what is the difference between T4 and T3?
The T3 is the one, mm, um, the ones that produce, no, ay, la tres, I don't remember that produce certain fun, no sé.
Which one is the active
The
form of the hormone?
active.
Yes, because one is the active form and the other one is the reserved form.
Mm, I don't know.
Okay, let me share my screen so we can go over it again, okay? You see my screen, right?
Yes.
Okay, here we have the axis, right? You told me you were right. Hypothalamic, pituitary, and thyroid axis, right? Here at this point, at the thyroid gland, we have this. I mean, the pituitary gland releases TSH, right? And
Yes.
this hormone, well, the TSH stands for thyroid stimulating hormone, right? So it stimulates these cells, which actually are the follicular cells, and they actually stimulate this enzyme, thyroid peroxidase. They stimulate this one to produce more hormones. And what are those hormones? Are T3 and T4. T3 is called that way because it has 3 iodines, and T4 has 4 iodines, right? The T4 is actually the reserve form, and the T3 is the active form. So T4 has to turn into T3 to be active, because remember, T3 is the active form of the hormone, active form, T3. So T4 has to turn into T3, and that happens through these enzymes. Deiodinase in Spanish would be desiodasa, okay? So these enzymes turn T4 into T3, which is the active form of the hormone. Okay, did you get it?
Yes.
Okay, so we were talking about the classification, right? And some other, let me, here, I think it is here. Yeah, we have the primary hypothyroidism, in which the affected part is the thyroid gland. The secondary hypothyroidism is when there's a failure in the pituitary gland, and the tertiary hypothyroidism happens when we have a defect at this point at the hypothalamus, okay? So both secondary and tertiary hypothyroidism are also known as central hypothyroidism. The most common one is primary hypothyroidism. Okay, which one do you have? I think you might have the primary hypothyroidism. And, and here we have how to identify each one of them. You were saying, right? Like when there is primary hypothyroidism, the TSH is higher than usual. However, since the defect is at the gland, it would not produce enough T4. So the T4 is lower than usual. So TSH higher than usual and T4 lower than usual, well, you have your diagnosis, which is primary hypothyroidism. On the other hand, we have the secondary and tertiary, or also known as central hypothyroidism, in which we have lower levels of TSH because the pituitary gland produces TSH, right? So when there is secondary and tertiary hypothyroidism, we have lower levels of TSH, and for instance, we have lower levels of T4. Do you remember what was subclinical hypothyroidism?
Subclinical hypothyroidism.
Yeah.
It was in an early form.
Yes. Okay. And what is it?
Hypothyroidism.
Okay. What does the patient have? Does the patient have any symptoms?
He starts to feel the symptoms.
So this patient does not have symptoms.
Yes, he starts to. No. In subclinical hypothyroidism, no.
Okay, yeah,
Doesn't
right.
have symptoms.
Yes, that is why it's subclinical. There's no clinical features. That is why it's called subclinical hypothyroidism, right? So you told me the treatment was hormonal replacement, which is levothyroxine, right? You, for example, you take this medication in which you replace your T4 and with this medication. What did you tell me it was?
Eutirox.
Okay, yes. Yeah, here in Bolivia, we have the same one. Okay, so so it replaces the lack of T4, right? And okay, do you have any doubts? What about the diagnosis? Besides this hormonal levels?
What do you mean? What by other diagnosis?
Okay, would you ask for any other complementary studies to diagnose this disease?
Besides that TSH?
Yes, TSH and T4, right?
Maybe the no, I took radiografía, ultrasonografía.
Yes, ultrasonography. Awesome.
Ultrasonography.
And that at the beginning of the class, I was telling you this this one. This is important. Actually, some people do not pay attention to the weight of the gland. However, it is important because in your report, your ultrasonography report, if you see it, most people report it according to the weight of the gland, right? So in a person who has hypothyroidism, the weight of the gland would be lower than 10. In a person who has had this disease for a long time, especially, okay? On the other hand, we have the hyperthyroidism, in which, for example, might report 60 grams, and you know that in the normal ranges are from 10 to 20. So if there is a gland which has a weight of 60 grams, you would already know that this gland is bigger than usual, right? So this is, if you see to your ultrasonography report, I'm mostly sure that if you see it, there will be you will see the weight of your thyroid gland. Okay, so this is important.
Mhm.
Okay, Valeria, so we're done with your 15 minutes. Let's have all the people together for the poll, okay?
Okay.
Okay, see you in a while.
Okay.
So guys, I was talking to some of your classmates, and there are some people would like to talk about some other topics about medicine in Spanish. As you might have seen, I like teaching this kind of stuff. So if you want me to, we can have classes in Spanish for us to understand each other in a better way. So let me know if you have any topic in mind, and we can do it. Okay. And also, I'm going to upload the presentation of yesterday's class, and also when we finish tomorrow, today's class. Okay. So let me know I'm going to upload some books also for some people to read what you might like. However, the better, I mean, I have some books, but I have I consider the best ones to be written in Portuguese actually. So if you have some basic knowledge of Portuguese, it will be easier. It will be easier for you. I also speak Portuguese, so if you do not understand any word or something like that, when I upload this kind of books, you can ask me. I mean, there's no problem for me, okay? So I'm going to start recording and we will go on with the survey, okay? Okay, guys, let's go on with the survey. Let me know when you're done.
I'm done.
Okay, thank you. Thank you, guys. I think you all did it. Yeah, really fast. Okay, so let me know if you want to talk about any other topic in Spanish, of course, would be uh, not in this platform, of course. Let me know, okay, guys? And I'll see you tomorrow. Have a good night sleep and good night, guys.
Good
Night.